Alrighty, good morning. Thanks for having me out. Roger, thanks for inviting me. It dawned on me as I made the 4-hour trip from Syracuse where it was cold, windy, and snowy. And I arrived here last night and it was cold, windy, and snowy. Usually on these trips, I'm somewhere at least sunnier. The one benefit you have here is you're flatter, you're not in a valley, and we have all those things plus cold, gray, fog, rain. We're cloudier than Seattle. So this is an upgrade. I got some sun today, right? So thanks for having me out. Happy to be here. There we go. As Roger said, my disclosures today, basically I write textbooks now. I haven't really worked with the pharmaceutical industry in about a decade as far as speaking or research. My career kind of took a pathway into administration and teaching. A pittance of royalties. I still have a day job. None of these are the top 10 bestseller book list, but they are fun to write. It's nice to see your name in lights every now and then, but there's not a lot of cash. So what are you all in for here today? We're going to talk about ADHD, and the goals and objectives are behind me. Disclaimer, I'm an adult psychiatrist, so even though it says child psychiatry here, this is much more geared towards adult psychiatry. Syracuse, New York is a college town. We have the Syracuse Orange Men, right, for basketball, and Orange Women who are doing relatively well. And we have Lemoyne, we have a community college, we have 2 major state universities, now we're north and south of us. So one thing that happens in my practice is I get folks who are 18 to 25, medical school, law school here too, maybe up to 30, that come in and say, I don't know, I came here to Syracuse, it's snowy, cold, windy, gray, and I caught ADHD. I need stimulants to study better. And we heard about debipolarizing. I thought that was a Syracuse term. But we have a lot of folks that come in with ADHD and they don't really have it. So again, we spend a lot of time picking through diagnoses, trying to make an accurate diagnosis. So my world is much more adult. So if you ask a child question, is there a child psychiatry person in the audience? You will come up and teach the lecture at that point. But I'll do my best. If I'm wrong, speak up. We'll talk a little bit about neuroscience, where does ADHD come from, and we'll get into practical treatment and management. Now here's a problem, we're running a little bit behind schedule. And I want to do my best to get us back on time or stay on time. So we need a vote, and I took out all the practice questions, right? But we need an interactive audience, so we're going to vote. So we can talk about complex diagnostic skills, I don't want to say complex, basic neuroscience of ADHD, and then treatment strategies, right? So diagnosis, neuroscience, treatment. How many of you want me to spend more time on diagnosis? How many want more neuroscience? How many want more treatment? All right, good. All right, so I'm going to blow through some slides here, okay? So there's about 400 slides in your slide kit. And I can't cover them all, but I will try to get more towards the treatment part more quickly. I think we have some time for questions and answers. And those of you who raised your hands for neuroscience and you're really, really mad, that Schwartz guy came up here, we wanted neuroscience, blame Roger, right? He's the host of the event. Dr. McIntyre takes all the blame. It's not me. You voted on how I pitched the talk, okay? No, Roger's a good guy. I'll try to cover a little bit of everything, certainly ask questions at the end. So let's move a little more quickly through the diagnostic thing. Do y'all know the DSM-5? Yeah, it's standard of care in the U.S., whether you love it or hate it. This is how we make the diagnosis. You ever get sued, that's the first thing the attorneys in the U.S. throw at you is a copy of the DSM-5, and they ask you if you know this book and make you quote parts of it for diagnostic know-how. So in the DSM-5, when it converted from the 4, they raised the age from 8 to 12, right? So expanded the diagnosis. Again, most people don't remember what grade school was like at age 5 and 6, but they probably remember 11 and 12 a bit better. So you get a little bit better history from your patients. The other key thing, and this has always been true, I think, but 2 settings. One of my practice credit questions really harped on this. My college-type students that come in telling me they caught ADHD, it's usually only at school and only when they're memorizing stuff that's boring. Right, and I say, well, what about when you play, club soccer at night? What about when you're out on a date? What about when you're at home and you're with your families and your parents ask you to do 4 or 5 chores on break? No, I'm great there. My relationships are great, but it's just memorizing. It's one sphere. Probably not ADHD. Probably an adjustment disorder. Probably part of personality. But make sure it's ubiquitous, that you see these symptoms everywhere. And your diagnostic calibration, to use Roger's term, I think goes way up. So make sure you take a much more global history. On the bottom, we still have the combined type, the inattentive type, and the hyperactive impulsive type. Way over on the end, we got rid of NOS and we use other specified. I'm on a really big thing. I'm a teacher and a trainer of med students and residents, and I harp on this all the time. That NOS or other diagnosis is a cop-out. Spend the time making an accurate diagnosis. Get collateral history. Get school records. I have several slides on this down the road. But increase the accuracy of your diagnosis. You're paid the big bucks being a psychiatrist to make diagnoses. If you're wrong, right? If you're wrong, you apologize, you go back, you reassess, you make a new diagnosis, but don't just falter around kind of guessing at the diagnosis at this point. So we really try to train people not to use those and be as accurate as you can. Here's the inattentive symptoms. You need 6+ for kids, you need 5+ for adults. So there's a little bit of difference when you get into the grown-up world. Behind me again, hyperactivity and impulsivity, they haven't changed too much. 6 for kids and teens, 5 or more for adults. What's the epidemiology? Kids about 11%, grown-ups about 4%. We'll have a dilemma maybe if we have time to talk about it. Do people really outgrow ADHD? So do half this group, the original 11%, outgrow their ADHD? How many of you have seen people outgrow their ADHD? Oh, come on. I keep hoping my 14-year-old's going to outgrow his. Yeah. So again, do they really outgrow it? I don't think so. I'll show you a graphic on that. If you think about it, schizophrenia, bipolar type 1, 1% disorders. This one's a 4% disorder in adults, so it is more common. So if you're not screening for it in your psych review of systems, you're not looking for it as a key comorbidity that can interfere with your treatment for depression, anxiety, etc., you're probably missing some. Certainly depression and many of the anxiety disorders are more prevalent, but it's about 4%, so it is there. So here's my thing about outgrowing the ADHD part. So on the bottom axis, you have preschool, little kids, all the way over to adolescence, college age, and if we strung it out further, you'd have people who are 50 in a midlife crisis like me. Yeah, 50 is a bad year, by the way. So what happens? The blue bar that you see, it's the inattentive symptoms when kids are really little. You don't really catch on to them. What do you see? It's the yellow and the orange stuff. This kid is out of control. He won't sit in the reading circle in preschool, won't sit still in kindergarten. They stand out as bad kids, bad students, right? They're always getting in trouble and redirected. So kids with hyperactivity and impulsivity get on the radar much faster. But they're more visible and they probably happen more often when you're a kid. Right? Now what happens when you're let's say an adolescent to an adult, the yellow and the orange bars, impulsivity, hyperactivity get less and less and less. Does anybody know why?
I think because the brain is sort of more quieter, it's more developed. And,
yeah.
makes a change with the circuitry.
Yeah, this is a great segue to my neuroscience section. Does the brain do something different, develop? I think it does. The frontal lobes come online, right? And you can start controlling some of your behaviors and activities. So I think that absolutely happens. My oldest kid is 18 and in college. He came home one day from health class at school and said, "I'm allowed to make stupid and ridiculous mistakes, Dad." It's part of being a teenager. And I'm like, okay. Well, because my brain hasn't developed yet to stop me from doing these things. So I'm allowed to go do all sorts of stupid things, yeah. But that may be right. I think the brain kind of comes online and we're able to think through stuff, make better decisions. The other thing is appropriate social anxiety, right? Is it okay when you're 14 to get up out of your seat, stroll around the classroom, and stand out? For most kids, no. So I do think it's brain power comes online, and even psychologically, kids realize, I don't want to be the center of attention this way. And they find a way to hold it in all day long, and what do you do if you're a 14-year-old with the last name Schwartz who lives in Syracuse? You save all that stuff for when you get home from mom and dad, right? They really rein in the behavior, and then their stimulants wearing off, which doesn't help, right? So I don't think they really outgrow it. I think there's a shift, and what you see in the blue bar is the inattentive stuff is kind of left there. And I think that ends up being the more impactful thing in the adults I see. It's also harder to pick up, right? So inattention, without all the hyperactivity and stuff that gets you on the radar, it kind of, unfortunately, flies under the radar, but is still impairing. So I do think there's a shift in symptomatology as we grow up with ADHD. And again, I won't go through these, but if you want to know on the left side what a kids look like with inattentive symptoms and how that inattentive stuff presents itself as they grow, follow across the screen. Same thing with impulsivity and hyperactivity. How does a little kid with ADHD different from a grown-up, let's say? And again, I'm getting to the point in my practice where I do have 50-year-olds, 60-year-olds, 70-year-olds who are being treated for ADHD, right? You know, back in the day, we didn't have as many treatments or as many stimulants. We didn't make as many diagnoses, of course. But I'm actually now seeing an age group I've never had to treat before. And some are coming back. They got downsized. They lost their corporate America job at age 55. They have to get into a new job, do more things. And they're like, yeah, I had that Ritalin when I was 16, 17. I hated it. I hated the doctors. I hated my parents, but it actually worked. Can I get back on my stimulant? I need to learn a new job, a new career. I can't sit through classes anymore. So sometimes I see that too. They have 30, 40 years of no treatment, and then they come back in. So clinically, again, we kind of voted down spending a ton of time here. I just listed the screening questions. They're mostly DSM-based. So when I'm interviewing people, they come in usually for depression and anxiety and things like that. And then at some point, I go into a psychiatric review of systems, right? So I have to ask screening questions on psychotic disorders, mood disorders, addictive disorders, eating disorders, 5 anxiety disorders, and now I ask these kind of questions. And they say no, and I move on. They don't have ADHD. If they say yes, now I got to dig into those DSM-5 type, a set of linear questions and check boxes. So again, this is the system I tend to use. And again, the other thing you do when you're taking a social history, so if you hate that little review of systems checkbox approach, we do a developmental assessment in our social history. So Syracuse, SUNY Upstate, really is still a psychodynamic and even Freudian based. We teach a lot of this. We pay a lot of attention to personality. We pay a lot of attention to development in our training. So we've always done this. But the other thing we do is we just ask, what were you like in grade school, middle school, high school, college, military, whenever you moved out and got a job? How were your grades? How were your relationships? And on the surface level, I'm looking for personality disorder, frankly, and the development of it. But you also can catch things like autism, because that tends not to change from going on. But I've caught a lot of ADHD. So if I forget to do this in my psych review of systems, which is kind of robotic and checkbox, I catch myself often in the social history. And again, these are the kind of softer questions I would ask when I'm doing that part of my interview. The longitudinal history is important. So as I said, in the folks that come to see me, they're usually upper teens, low 20s, and they say, all of a sudden I have ADHD and I want help. I'm going to stick to that story. So I asked them all these questions. I said, well, what were you like again in school? And you go backwards. So I think that's really important. You can't just take the surface level tip of the iceberg or everybody walks out with a stimulant, right? So again, due diligence, step yourself backwards. How many of you deal with addictive patients? They can come in addictive and you have to trace backwards. When did it start? What was the triggers? How many relapses? It has a very similar feel. You have to go back retrospectively, really see what the pattern of their ADHD is and when and where did it really interfere with their life. Comorbidities, I bumped into somebody in the hallway and they asked me to talk about comorbidities. That'll come a little bit later in the talk. If you have questions about how to treat anxiety and ADHD, bipolar and ADHD, some of those are in my slides, but you can ask questions. But comorbidity in adults is the norm. We get accused, I think, in psychiatry, if you have this DSM, you find 4 or 5 diagnoses in everybody. It's just part of what you do in psychiatry. Because people have 4 or 5 things. I think it's real. So if you do a really thorough history review of systems, you find stuff. It's rare for me to have somebody come in with just ADHD, just PTSD. They usually have multiple things. So if you really go through it, you find multiple disorders. Unfortunately, the FDA in the US, all the drugs are FDA approved for single disorders, right? They don't measure how do you treat bipolar and ADHD at the same time. There's literally no data that helps us when you get into those kind of weeds. So please look for comorbidities, and you certainly have to treat those. Confirming history. Sometimes our patients are bad at history, even maybe they don't remember their middle school years. Did I mention 50, like me? Yeah, when you're 50 like me, you know what your school records look like? They were handwritten, right? Do you guys remember handwriting? Yeah, in the US, so they were handwritten school records. Tom was kind to have in class, good student, never got in trouble, right? All handwritten stuff. And then what happens is they took a photo of it and put it on microfilm or microfiche. And how many of you know what that is? You're at least 50 like me, right? So what happens is, do you think I can really get those records from Buffalo, New York? No. They're gone somewhere, and those little film strip projectors don't even exist anymore to read it. So, but everybody who's probably 30-ish and under, it's all on a computer. And so we have somebody comes to my office, I say, hey, can you get your school records, sign a release, I want to get them. And if it's littered with won't sit still, blurts out answers, impulsive, disruptive to class, I'm like, yep, you got a diagnosis. Yeah, and if it says perfect, I don't know, it's kind of hard to prove that you were impaired at school. Maybe they're inattentive type, I don't know. Get school records, it's easy. And it's calibration, again, I'll keep stealing Roger's term. We get better at making the diagnosis when we get that historical evidence. Or, I was always trained with bipolar disorder, right? That, how good is the bipolar's history when you say, have you ever been manic? So my understanding is, and I was trained this way, and if the facts are wrong, Roger will correct me, but about half my bipolar patients say, nope, I've never been manic. Nope, it's never happened. And half of those patients, it's psychotic denial, to use a Freudian defense, right? They really don't remember. The other half, they lie. Who's the famous TV doctor that say patients lie? House? Do you remember that show? Yeah. So some of my patients say, Schwartz, you don't get it. Being manic is like cocaine without the cocaine. How many cocaine addicts like their cocaine being taken away? Right? So patients will lie and say they weren't manic. Though if I bring in a significant other, family member, somebody close, and I say, how many manic episodes? The patient goes this, and what does the spouse do? So same thing with ADHD I'm finding. If you can find somebody else that has known the patient longitudinally, get permission, bring them to the interview, get a phone call, have them complete a checklist. Again, calibration, long-term longitudinal history. Get school records, family history by somebody reporting. You now have a very accurate diagnosis. Now if you decide to write a stimulant, it's going to work the way it was designed and the way the studies show. If you don't find all the comorbidities, you may be treating the wrong illness. How many of you love rating scales? How many of you originally did not like rating scales and then learned they helped you? A couple more? That's how I did. I hated rating scales. None of these gosh darn attendings made me use them. And then I was doing research, and by the time the patient walked in my office, I knew if they were better, worse, or the same. And then I could focus on certain symptoms based on their rating scales. I had actually more time to talk about their psychosocial stressors, compliance, adherence, work on those core psychotherapy skills. So as much as I frankly actually don't like doing rating scales, they actually give me more time in session. And they've been very helpful. So I have a whole series on rating scales. This is the most common one used for ADHD. This is not diagnostic. I've seen people with personality disorder, addictive disorders, score high on this thing. But again, take a good history, longitudinal, look at comorbidities. But this at least gives you a blood pressure cuff of how much ADHD symptomatology they have. You start a stimulant or something else, you bring them back to 50% better, 80% better. Treat to remission, just like we teach you in bipolar and depression. Keep pushing the pharmacology, maybe some psychotherapy, but try to get the rating scales down to 0. This is what it would look like. The myths, I won't cover them all. These are actually really easy to deploy in practice. You just have to kind of bite the bullet, get good at it. If anything, I could see more patients per hour by using rating scales, but I've actually found I can spend more quality minutes with the patient, not just typing away at my EMR these days. So I've learned to actually really love them quite a bit. All right, let's switch over to some neuroscience here. Very genetic disorder. 76%, and I'll quote some studies here, probably more biological, more genetic inheritance than schizophrenia or bipolar disorder, certainly less than depression and anxiety. So it's here, and with all the genetics and heredity, we start looking at genes, right? What genes can cause the symptoms that create ADHD? So you look at the more bold-faced bullet points. Why did we pick dopamine and norepinephrine as the genes we wanted to look at? Because our stimulants have been working since the 1950s to treat ADHD, and they raise serotonin and norepi. So we specifically go looking for genes that change the neurocircuitry where dopamine and norepinephrine is concerned. Notice serotonin is in there. We're kind of in our infancy at looking at serotonergic genes. There is interplay between neurochemistry, right? And then the other one, which is kind of cool, is the neurodevelopment stuff at the bottom. So brain-derived neurotrophic factor. Does the brain develop normally or not? And is there a neurodevelopmental hypothesis where you get bad genes, your brain develops wrong, so you develop things like ADHD, schizophrenia, etc. So here's a map that you don't have to memorize. I've circled the things in red that are dopamine-based. So if you use this approach, there's dopamine receptors like D1 and D2. There's the dopamine transporter, DAT, the reuptake pump. Mutations in there in ADHD patients can lead to behavioral problems, brain plasticity and developmental problems. So we're getting better at this kind of target gene approach. Now, how many other genes are in? There's like 50 genes in here. How many mutations do you need to catch ADHD? I don't know, 100, 300, 400? I know Roger was talking about gene testing. I think there are certain places in my practice I use it, but I don't have a gene panel with 50 ADHD genes yet. So I'm not quite there. So I agree, down the road, that would be a good thing to do. Look at the square box. Anybody know what gene DISC1, what's the name, full-length name of that called? Isn't it something like disrupted in schizophrenia 1? You're like, what's a schizophrenia gene doing in ADHD? That's not fair, right? So that's kind of a neurodevelopmental gene. So we think schizophrenics' brains develop a spin, right? Or sorry, non-schizophrenics, the normal brain spins and rotates. It's asymmetrical. Schizophrenic brains lose their symmetry. It's a loss of asymmetry. And this gene may be to blame for part of that. And it also happens in some ADHD patients. So is there a neurodevelopmental problem that leads folks to get ADHD? It may not just be dopamine, right? It may be the way your brain grows up. So here's a slide that might shed some light on this. So again, if you look at the left side of the screen, let's say a newborn, less than a year, you only get 1 or 2 neurons floating around that are not big and branching, right? So the brain's kind of disorganized because there's not a lot of stuff in it yet. And then when you get to be around age 6, 7, 8, right, you're in your elementary school years, there's tons of these things, right? There's millions of neurons, they're all touching each other and poking each other. There's too many of them. And then we mentioned development, so you get around 14, 15, you start hitting puberty, your frontal lobe starts to do a bit better. There's appropriate pruning, right? There's less neurons, there's less, you're getting rid of the stuff you don't need. And then I think maybe your frontal lobe comes online and says, I'm not going to do as many stupid or silly things as my kid would have put it. This is the normal development of the brain, right? Not a lot, too much, appropriate pruning and reduction. Certain ADHD patients, there's a 2-year delay in this. The brains are different, right? Not every ADHD patient, but we have findings that brains are just different. They develop slowly. So maybe you get a mutation in something like DISC1, and it causes your brain a 2-year delay in hitting the normal maturation process. That could be one cause of certain patients with ADHD. This is what I call my inverted U-shaped curve, right? So it's an upside down U. And here's the other thing that I think happens. Remember, the brain likes homeostasis, right? We're talking about things like norepinephrine and dopamine. That's the bottom axis here. So the brain likes a perfect amount of dopamine, for example. And if you look at the vertical axis, that's functioning. So at a perfect amount of dopamine, you go straight up to the middle of the U-shaped curve where it says normal. I can give a talk like this, I can interact, I can program. I am functioning perfectly with the perfect amount of dopamine. Now what if, I don't know, what if I was on the stage once and somebody threw a shoe at me? It happened to one of our presidents in the US at one point. But I had PTSD now because I was assaulted, so I'm going to be on the stage a bit more hypervigilant. I have a little more dopamine. Which one of you has the heaviest shoe out there? And I'm not focusing on my talk, and you don't get as good of a talk from me. I have too much dopamine. It might self-preserve me. I can duck if Roger throws a shoe at me from the back row. You big feet, Roger? Your shoe would hurt, right? So I'm paying attention to this, and I just goofed up my talk with you all. Too much dopamine, bad thing. So I could do some meditation, something like that. I could calm down. I could get mastery over my trauma experience, push myself back to the perfect dopamine level, give a great talk. Now, what if before I came in, I snorted a bunch of Coke in the hallway and overdid it? I mean, I talk fast being a New Yorker, but it's just who I am. It's not snorting Coke in the hallway, but if I did too much, might I come in here and hallucinate, get paranoid, get sick? Sure. Right? We do too much dopamine. This is what happens with schizophrenia naturally, right? What do? We block D2 receptors, which slows down dopamine firing. We push the hallucinations back to normal because dopamine goes back to normal firing. So the opposite probably happens in ADHD, right? So I want the right amount of dopamine and norepinephrine keeping me on track and focused and giving a good lecture, right? So my ADHD, let's say, doesn't interfere. And if I develop a developmental problem, I have bad receptors, bad enzymes, and my dopamine kind of isn't as aggressive in getting to my cortex, I'm off track, I'm off base, my inattentive symptoms, I've shifted to the left. So again, if I take a stimulant before I come in appropriately, my dopamine comes back up, I'm perfectly in the middle, give a great lecture. So what we think happens, again, short story long here, you inherit genes, maybe it's about the development stuff, but maybe you get genes from mom and dad where you're not so good at dopamine or norepinephrine, right? You might have 30, 40, 80, 200 mutations, but you don't manage your dopamine well. So your dopamine levels go down, your receptors don't fire right, your brain neuroanatomy isn't functioning optimally, and now I can't focus or pay attention, right? I've shifted on that U-shaped curve to the wrong side. Then I give people a stimulant, for example, norepinephrine goes up, I put you back in the middle, you function optimally, you're in remission from your ADHD, and life is good. So this is the thing, when people walk through my office, I kind of in my mind envision, where are they sitting on this curve? What drugs do I have that can push their chemistry up or down? And I can do this with schizophrenia, mania, anxiety disorders. This is theory, and there's no studies on this. But if you want a way to conceptualize why I'm going to prescribe a med, in my country, the FDA says so. Treatment guidelines might say so, but I think your brain neuroanatomy is off. I think dopamine lives there. I'm going to push your dopamine up, and I'm going to get you right size as far as brain homeostasis. So what are those circuits? The mesocortical, we talked about this in the negative symptoms of schizophrenia, but you have from the midbrain ventral tegmental area pushing dopamine up to your frontal cortex, right? So the frontal cortex is out here. So I now have just come to Canada and made faces at all of you. You let me do this, right? It's right here. It's outside part of your brain, dorsolateral prefrontal cortex. I'm going to show up for a talk. I'm going to have the talk prepared. I'm not going to make many mistakes. I'm going to meet the host. I'm going to come in on time. I'm going to keep track of 20 things at once, even where the clicker is. And it's executive functioning, right? My ADHD patients can't do that. So I suspect there's some faltering in dopamine making its way up to the dorsolateral prefrontal cortex. So again, what drugs do I own in my armamentarium, on or off label, that can push dopamine or norepinephrine, parallel pathway? Stimulants, atomoxetine, certain antidepressants. I can strengthen it. So if you get bad genes where that circuitry is low, I can give you monoamines to push it back up, make these parts of your brain function better. This might be one of those pathways that's a drug target. So we have things like this, right? So, yeah, Schwartz, that sounds like hogwash. Show us a sexy functional imaging slide. Prove it. That's what you were all thinking. So if you look at the controls on the left, there's these pinpoint, right? Anterior cingulates. Those two little white hot red yellow dots, that's vigilance, right? I can pay attention to my talk, ignore Roger making faces at me, ignore the person sleeping over here, ignore that's a little cold in here. I'm giving you the talk. I am focused on you. I am super vigilant. My anterior cingulates, white hot, right? I don't have ADHD. So I'm working. Look at the brain on the other side, the ADHD brain. Their anterior cingulates are gone. No, that's not right. They weren't born without anterior cingulates. They're just not firing. So they are hypoactive. That U-shaped curve, I want them firing at a normal rate, but they're kind of doing this, right? So what if I can give somebody a stimulant or something like that and turn them back on? That would be exciting, right? So this is kind of a biomarker. Can we stick people in scanners? Again, not ready for prime time. But the idea is, what if we could show we can bring those things back online with certain medications or psychotherapy? But look at all, on the ADHD side, look at all like the accessory insular cortex. It's just firing really big. Look at all the calories that brain is burning just to stay on focus, right? It's the wrong part of the brain. It's expending a lot of energy. They're using the wrong part of the brain to stay focused. So again, can you do things with cognitive therapy? Can you do things with medications to bring their vigilance online? Sure you can. So brains are abnormal. This might be a developmental thing. This might be they didn't get good genes from mom or dad for dopamine processing. So that circuit is now underactive. So this is another representation. On the top level, you have genes from mom or dad. You have environmental influences. The next level is you have abnormal brain circuitry, right? You have mutations, bad proteins, receptors, enzymes. Your brain can be hyper or hypoactive. And then we do psychometric testing, right? We send you to the neuropsychologist, normed against millions of kids and adults. Yeah, this looks like ADHD. So calibrating diagnosis, if you have access to a neuropsychologist, all the pen and paper tests, it's really kind of cool. Helps confirm or deny your diagnosis. And then at the end, on the bottom, you see the symptoms. That's your phenotype, right? So genotype, endophenotype in between, and the phenotype. So you have enough mutations, you have enough bad neural circuits, borrowing from Stephen Stahl's work, and you have enough of those things go on, you develop outside symptoms. You develop enough outside symptoms, and now you meet criterion for the DSM-5, and you go and get yourself treated. The mesocortical system also has the ventromedial prefrontal cortex, right? So if you were to stick your hands up between the lobes of your brain and poke your thumbs out, you're tickling the ventromedial. Anybody remember the Friends episode? Coming into Canada and insulting everybody by doing this and this, right? Roger will never ask me back. But that's how you teach the ventromedial prefrontal cortex. Stick your thumbs out. That's the emotional processing center of your brain, right? And how many of you think that that's wrong in ADHD? Have you ever met an ADHD kid in particular who's more labile emotionally? Are they bipolar? Do they have really some sort of emotional issue here? And the answer is yes. And it's due to the ADHD. So Ferrone is a guy that we stole from Harvard. He's with us now. Barkley was with us for a while. Asherson's up here in Canada. There's a lot of research showing that ADHD kids are emotionally labile. And it's not from depression. It's not from stress at home. But it's not made the DSM-5 yet. But stimulants and atomoxetine help that lability, right? So you fix the inattentive stuff, the hyper stuff, and the emotional stuff. So a lot of people are arguing there is an affective component to ADHD that's really not measured or studied. These are some things in the environment that can cause ADHD, make it worse. Here's the comorbidity part of the talk. If somebody walks through your office with anxiety, please screen for ADHD. They come in with ADHD, screen for anxiety, right? People with ADHD, the ADHD disrupts their ability to have the job they want, the raise they want, the relationships they want, right? And then they get stressed, anxious, depressed, right? So I do think there's a social impact of having ADHD, but sometimes these are all brain things, and folks have comorbid problems. And we get into treating adults, you gotta treat the big picture. I can treat the ADHD, I don't know if the depression will get better. I can treat the depression, the ADHD might not get better. If we get lucky, everything gets better at once. But again, make the comorbidity diagnosis, you gotta treat all parts of it or your outcomes are going to be worse. There's some overlap with autism. I've seen plenty of autistic kids and adults that have ADHD. So again, treating there makes sense. Learning disability, some people just can't memorize. Doesn't mean they have ADHD, right? So I can't build anything straight or square. I could have never been a surgeon. I get lost if I drive places, right? So is that a learning disability? No, but I've never been good at it. It doesn't mean I have ADHD. So you will see some patients come in with very isolated deficits. I don't know if a stimulant's going to help them or not. And then personality disorder, I do a lot of work in that area. My antisocials, my borderline personalities, all look like they have ADHD. Might they really? Yes. If they have it, treat it. If it's part of the personality, treat the personality. So European guidelines are the most modern ones. The US guidelines are years old. But again, take history, accurate diagnosis, comorbidity, DSM-5 criterion. Look for family history, very genetic, right? So that helps you solidify a diagnosis. There's 3-4 key family members with bona fide ADHD. We haven't talked about that yet. Does psychotherapy work? Yes. Effect sizes are very small. The cognitive behavioral therapy approach for executive functioning is probably the most validated. But I don't think, and I'm a psychotherapy guy, right? I do motivational interviewing, I do IPT, and I was trained in psychodynamics. But in ADHD, the effect sizes are small. You're going to do better putting people on medications. So again, if you really look at the data, I'm not poo-pooing psychotherapy, but in the world of ADHD, the meds really do kind of rule. And you'll get better responses more quickly and more thorough responses. But listed for you are some of the psychotherapies that are out there with data. And again, medication management, even for mild ADHD, can be very effective. And the first line psychotropics are the stimulants and atomoxetine in the US. We're going to get into treatment here. You'll see my handout is based on US meds and FDA approvals, so you'll see some drugs you don't know. You guys have two here, like Foquest and bifenton is relatively new in the US. I don't have some of yours either, so it kind of works out. But stimulants tend to be front line, atomoxetine, guanfacine, clonidine second line, and there's all sorts of off-label third line stuff we do for more treatment-resistant folks. The stimulants all work equally well per the FDA in the US, whether it's an amphetamine product or a methylphenidate product. So how do they work? They improve dopamine. They block that dopamine transporter, right? They're a dopamine reuptake inhibitor. So you're going to increase dopamine in the synapse, and hopefully that helps those neural circuits and brings them back online. The amphetamines, which I think are the more aggressive stimulant, and that's putting on my pharmacodynamic geek hat for a minute. What do? That pump, they don't just block it, sometimes they reverse it, and you start pumping out dopamine, right? It's a little more aggressive. And sometimes that vesicle VMAT system comes and dumps out dopamine. It has 3 mechanisms of action, right? That sounds aggressive to me in a pharmacodynamic way. So I do think the amphetamines can dump out more dopamine into a synapse. Does that make them better? I don't know. The data doesn't say that, but it's more aggressive in my mind. They also block the reuptake pump for norepinephrine. So these are noradrenergic, dopaminergic drugs. They all carry risk of addiction. In the US, they're class 2 drugs, and in the US, class 1s are the illegal addictive drugs. And if you overuse them, push that U-shaped curve, psychosis, paranoia, hypervigilance. In kids, they stunt growth 1/4 to 1/2 an inch. Most of my 50-year-old patients, I'm milking that joke, right? My midlife crisis joke. The 50-year-old patients like losing 5 pounds, right? And so it's not usually a side effect in grown-ups, but be careful using these drugs, let's say in anorexia-prone patients. The problem I run into with my 50, 60, 70-year-old patients with ADHD is cardiovascular. I've had a couple people, unfortunately, get AFib, A-flutter. Right? So these things raise heart rate, blood pressure a little bit, so you do need to be careful the older you get if you use them and push the doses. And they're activating, right? Sweaty, shaky, jittery, insomnia. So the longer acting the stimulant, the more likely you have those side effects that you're going to need to contend with. So these are typically the frontline drugs that most guidelines suggest to use. The non-stimulants, atomoxetine is a norepinephrine reuptake inhibitor. Clonidine and guanfacine are alpha-2 agonists. They don't carry any addiction risk. Their effect sizes are smaller. They do not work as well as the stimulants, and they work better for inattentive symptoms typically than the hyperactive impulsive ones. NRI, atomoxetine somehow is sedating. We've always been taught as you push up norepinephrine, you make people more wired. This drug is somehow horribly sedating for a lot of my patients. I remember asking Stephen Stahl at a conference once, I don't get it. You preach that norepinephrine wakes people up and makes people focus, and this drug makes my patients tired. You lied to me, Stephen Stahl. You guys know Dr. Stahl in his textbooks? Yeah. He said, geez, Tom, GOK. What? It's like, God only knows why this drug is sedating. I have no answer why. Here's my mentor and my guru, the guy I kind of grew up following and disciple of, and he has no answer for me. But it is a sedating drug that tends to mitigate over time. So a quick comment about the alpha-2 agonist products. How many of you are sitting here? Schwartz is up here doing this stuff about norepinephrine in the middle of the U-shaped curve, and we want to push norepi to get people better with ADHD. And how many of you went to medical school, nursing school, PA school, and learned that the alpha-2 agonists lower norepinephrine to lower blood pressure? Any of you with me? Did you learn that in school somewhere? Yeah, it's counterintuitive. Why would I give a norepi dampening drug to an ADHD patient? At least that's what I did when these drugs were being studied. It's fascinating. For blood pressure, you're absolutely right. We want to dampen norepinephrine in the periphery, and that's what these drugs do. But in the central nervous system, the alpha-2 receptors in the frontal lobe sit on glutamate neurons. And your glutamate neurons are the ones that control a lot of downstream function, right? Other parts of your cortex, your limbic system, part of the glutamate hypothesis of schizophrenia. It's the outer part of your brain that controls a lot of downstream functioning. So what if we use these drugs to improve signal to noise, that U-shaped curve, and your neurons fire more in concert in your frontal lobe to pay attention to things? It's a fascinating idea. So theory, but you're actually using a norepinephrine receptor on a glutamate neuron to get better control of focusing and attention. So it's not dampening norepinephrine for the illness we're discussing today. So working through treatment strategies. For really little kids, I have almost no experience in 3, 4, and 5-year-olds. But if you look at the data, behavioral therapy first, because we don't want to put kids that young on drugs. The amphetamines have the best data in the US, followed by the methylphenidates. This, again, I'm borrowing Stephen Stahl's textbook images here. So if you look at the left side for your middle-aged kids through teenagers, typically the slow-release methylphenidates are started first. And then if those fail, you go to a slow-release amphetamine. Again, in reality, the data is they both work well. My clinical experience has been there's an inch more side effects in the amphetamine drugs over the methylphenidates. I also find when my methylphenidates fail that my amphetamines do a little bit better. So it's just personal anecdotal history. But you really could start with either one. The guidelines tend not to care. And then if those fail, you actually then get onto the weaker drugs. But most guidelines say go for the stimulants. They work 70-80% of the time. They're really good. Largest effect sizes in psychiatry. So you can do that. The immediate release drugs we tend not to use. Kids don't want to go to the school nurse. They kick on and they kick off, increasing their drug likability and theoretical addiction profile. So the only place I use immediate drugs, both in adults and kids, is my stimulant, my long-acting stimulant wears off at 4 o'clock. I have to study for 3 hours when I get home. Then I put the immediate one there, cover them for 3 hours, and it goes away. They sleep okay. But I tend not to use a lot of the immediate release drugs unless they're going in surgically that way. Now on the right side of your screen, and I agree with Dr. Stahl on this is now anti-guideline. So maybe I'm a bad guy and I'm a rebel. So Tom Zaz was one of the psychiatrists at Syracuse. He was kind of a rebel. The myth of mental illness guy? I mean, yeah. So I'm going to be a rebel today. I don't follow the guidelines for adult ADHD. You can. You have to make your own decision as a clinician. But what happens is I use the non-addicting or low-level addicting drugs first, even though they don't work as well. Why? My patients are comorbid with other things. They tend to be addicted to stuff. There's other contraindications that makes using a stimulant a negative thing. My patients have to earn their way to a stimulant, so I try the safer things for them, the things that might treat their comorbidities better. And if those fail, then I move to slow-acting methylphenidate, slow-acting amphetamine, and move my way up the chart. The guidelines here would say if you have an adult with pure ADHD, please use a stimulant. Again, same story, they work great. So on that level, I think you can take that approach, but if your practice is like mine, my folks are depressed, they have PTSD and personality disorder, and some have addiction. So it's not as easy for me to get into stimulants. So maybe that's my personal practice bias, but the guidelines would say, unless there's a contraindication, use the stimulants first, kind of make it look like the teenage and adolescent side. So I'll leave you with that dilemma too. You'll have to decide in your own practice what's the right thing to do. Now you have a whole slew of tables that we can skip. A lot of them are US drugs. I stole this off from one of the vendors outside, right? So the CADRA guidelines will have the exact same table for you. I Googled it and got a PDF of it as well. But if you want a list of how to use the drug, how to dose it, what side effects to use, there are some tables. They're probably this big. You probably can't read them in your handout. But you can certainly get this CADRA guideline as well. But it's broken down into amphetamines, methylphenidates, NRIs, alpha-2 agonists. And so you can go through those at your own time. I will comment on modafinil. So modafinil is about 4 FDA-level trials. It worked better for inattentive symptoms. The company that made that drug didn't go forward with the approval. 2 kids developed Stevens-Johnson. So they didn't want to be the new lamotrigine or Lamictal. They didn't think people would prescribe it if we psychiatrists were scared of rashes. The FDA said you need more monitoring, so they pulled the plug on it. So that does work, but the kids, one kid was on Augmentin, another kid on Depakote. Both drugs known to cause rash. Is it really the modafinil or I don't know. So I don't use it in kids with ADHD, but my grown-ups, I've used a ton of it off-label for depression augmentation. It's a class 4 addictive drug in the US, not class 2. So that's on my lower shelf, and there's pretty legit data with the modafinil product, particularly in kids. Then we have the blood pressure type pills, atomoxetine. I will comment at the bottom on bupropion. How many of you have been rebels and used bupropion for ADHD? Yeah, NRI, DRI, it's cortical, not limbic, so it's not addicting. Those are the 2 transmitters I want. And in my world, if the patient is depressed, seasonally depressed, or wants to quit smoking, and they have ADHD, it's a win-win-win drug. Right? It's covered for all those things. So we use a fair amount of bupropion off-label in our adult population. I don't think you have any of these. These ones are coming to market in the US, so we must have a lot more kids and adults with ADHD because we keep getting new versions of stimulants. So you have 1 or 2 coming to the market in Canada, and we have several. Some of these are already out, by the way. So there's more and more treatments. It usually changes the slow release mechanism. So what do I do in practice? Start low, minimize side effects, but use the full dose range. Don't quit at just 10 milligrams of, let's say, Ritalin equivalent. Use the full dose range. You probably get better responses. You certainly can get more side effects. Monitor weight in your adults, your vital signs. We have to monitor for abuse in the US. We can do a drug screening. We have an eye stop where we check their pharmacy records to make sure they're not doctor shopping. And then you certainly can add the alpha-2 agonist for better symptom control. And the number one thing we do, if somebody gets revved up on their stimulant, we use one of those alpha-2 agonist drugs like clonidine. It actually further treats the ADHD and dampens their side effects. It's one of those combination strategies where you improve efficacy and lower side effects. Try not adding 2 stimulants together unless you're going to use that really surgical immediate release for some focused control. Why add 2 NRIs together? Doesn't make sense. They're both doing the same thing. Don't add 2 alpha-2 drugs together. They're doing the same mechanism. People are really anxious. I don't use a ton of stimulants because they get more anxious. People with terrible insomnia, I try not to use stimulants. Sometimes I have to. People at cardiovascular risk, I get them cardiac cleared with their primary care doc or if a cardiologist weigh in if I think they're at risk before going to a stimulant. And again, addiction is a problem. So I'll end with, there's a couple tables here. What if you have somebody with ADHD and depression? Here's ideas for you. What if they have ADHD and anxiety? There's ideas for you. I have tables like this all through my books about at least what I do when people have ADHD plus bipolar, ADHD plus OCD. But I think about the drugs that can raise norepinephrine for the ADHD and serotonin, usually for the depressive disorder, the anxiety. I really like the SNRIs in my comorbid patients. And again, maybe we get to a stimulant, but I want to try the drug that fits the largest profile. All right, I will quit there. What's our plan now, Dr. McIntyre?
Okay, well, first of all, thanks, Tom. That's excellent. Thank you very much.